Welcome to this webinar, introducing a new and innovative technology for managing bleeding and supporting intranasal structures after surgery and trauma. My name is Dr. Howard Levine, an otolaryngologist in Cleveland, Ohio, in the United States. A very special thank you to Dionysic, a company based in France, whose motto, "Smartly Designed for You," is creating technology to help ENT patients. We welcome to this webinar nearly 350 physicians from over 50 countries to be introduced to Cavity, an innovative and unique intranasal balloon. The large number of attendees today speaks to an interest and curiosity in how better to manage these problems. Cavity appears to provide a new and different solution. We're fortunate to have an outstanding faculty who've had clinical and research experience with Cavity. Today's webinar, you'll be introduced to Cavity. You'll learn the results of a pilot study performed at Strasbourg University Hospital in France and understand the clinical indications. At the conclusion, we'll have time for questions and answers. So now, let me present our renowned speakers. I'm honored to introduce Professor Mustafa Gerek. Professor Gerek is a member of the Department of Otolaryngology, Head and Neck Surgery at the Gökhan Medical School in Ankara, Turkey. A brigadier general in the Turkish Air Force, he has led the Gökhan ENT department to become a flagship Turkish institution. Professor Gerek serves as Vice President of University Health Sciences. He's currently the President of the Turkish Rhinology Society. Professor Gerek is the author of numerous ENT research papers. Professor Gerek will provide us an overview of the problem of epistaxis and how it's presently managed. I now turn the webinar to Professor Gerek.
Thank you very much, Professor Levine. I'm really honored to be a part of this webinar. And as you said before, I will make a quick overview about epistaxis. And then Professor Debry is going to share his experience on this issue. And you know that the epistaxis, or bleeding from the nose, is a common complaint. Nosebleeds are reported up to 6% of the population, with peak incidences in those under the age of 10 and over the age of 50, and appear to occur in males more than females. The epistaxis is rarely life-threatening, but may cause significant concern, especially among parents of small children. More epistaxis are benign, self-limiting, and spontaneous, but some can be recurrent. You know, the vast majority of the nosebleeds occur in the anterior part of the nose from the nasal septum. This area is rich, endowed with blood vessels, which is known as Kisselbach plexus here. And this region is also...
Professor Gerek, could you share your screen with us, please, if you have some images to show us?
Oh, really? I'm sorry.
That's okay. We'll give you a moment to get your screen shared. I know you have some beautiful images, and not a problem.
Sorry. I think I shared it. So let me begin from the beginning.
We can see this wonderful. Thank you.
Yeah, okay. I'm sorry. Actually, I turned the third slide. Yeah.
Please go ahead.
Thank you very much again, Professor Levine and the other friends for having me share this webinar with you. You know that the epistaxis, or bleeding from the nose, is a common complaint. Nosebleeds are reported up to 6% of the population, with peak incidences in those under the age of 10 and over the age of 50, and appear to occur in males more than females. You know that the epistaxis is a rarely life-threatening, but may cause significant concern, especially among parents of small children. Most epistaxis are benign, self-limiting, and spontaneous, but some can be recurrent. We know that the majority of the nosebleeds occur in the anterior part of the nose, from the nasal septum. This area is richly endowed with blood vessels known as Kisselbach plexus, or little area. Bleeding further back in the nose is known as a posterior bleed, and it is usually due to bleeding from the Woodruff plexus, a venous plexus situated in the posterior part of the inferior meatus. And posterior bleeds are often prolonged and difficult to control. Also, They can be associated with bleeding from both nostrils and with greater flow of the blood into the mouth. When we look at the pathophysiology of the epistaxis, the nasal mucosa, we know that, contains rich blood supply that can be easily ruptured and cause bleeding. Sometimes this rupture may be spontaneous or mostly initiated by trauma, as we know it as a digital trauma. And also the high blood pressure tend to increase the duration of the spontaneous epistaxis. Anticoagulant medication or disorder of blood clotting can promote and prolong bleeding. Spontaneous epistaxis is more common in the elderly as the nasal mucosa, the surface, becomes dry, thin, and blood pressure tends to be higher in those adult patients. The elderly are also more to prolonged nosebleeds as their blood vessels are less able to construct and control bleeding. The most intranasal nosebleeds can be stopped by applying direct pressure, which helps by promoting blood clots. Those who suffer a nosebleed should first attempt to blow out any blood clots and then apply pressure for at least 5 minutes up to 20 minutes. This pressure should be firm, and tilting the head forward helps to decrease the chance of nose and airway obstruction as seen in the picture on the right. When attempting to stop the nosebleeds at home, the head should not be tilted back. Swallowing excess blood can irritate the stomach and can cause vomiting. Those with nosebleed that last longer than 20 minutes with any precautions taken at home should seek medical attention. If pressure and chemical cauterization cannot stop bleeding, nasal packing is the mainstay of treatment to control the epistaxis. There are several forms of nasal packing that can be contrasted by anterior nasal packing up to posterior nasal packing. Traditionally, the nasal packing was accomplished by packing gauze into the nose, thereby placing pressure on the vessels in the nose and stop the bleeding. Traditional gauze packing has been replaced with products such as Merocel or Rapitrino. Also, there are several other dissolved packing materials that can stop bleeding through the use of thrombotic agents that promote blood clots, such as Surgicel. The thrombogenic foams and gels do not require removal and dissolve after a few days. Posterior nasal packing can be achieved by using a Foley catheter, blowing up to the balloon when it's in the back of the throat and applying traction. Also, nasal packing has some complications. These are abscess, septal hematomas, sinusitis, and pressure necrosis. In rare cases, toxic shock syndrome can occur with prolonged nasal packing. Ongoing bleeding despite good nasal packing is a surgical emergency on the other side and can be treated by endoscopic evaluation of the nasal cavity under general anesthesia to identify the elusive bleeding point or to directly ligate the blood vessels which supplying the nose. These are some samples. We can use unipolar cautery. This is a sphenopalatine artery, bipolar cautery, or ligation techniques to anterior sphenopalatine artery, or if there is a severe bleeding, anterior maxillaris interna also can be ligated with the clips, as seen here. These are very excessive bleedings, sometimes during the surgery or sometimes just instantaneously in the nose. And also technology is used to control the epistaxis. A coblation instrument also can, another tool that we can use to control the epistaxis just during any kind of nasal surgery or a spontaneous epistaxis. And lastly, this is the last slide. If there is an excessive or severe bleeding, the bleeding can be also stopped by intra-arterial embolization using a catheter placed up to the bleeding vessels by an interventional radiologist. As seen here, the catheter is placed there. And the continued bleeding can be an indication of a more seriously underlying conditions. As seen here is that the coils are placed to prevent the nosebleeds here. Thank you very much for your attention, and I tried to quick overview about epistaxis.
Wonderful. Thank you, Professor Gerek, for this superb overview on epistaxis. That's going to help to frame the next and important part of our discussion. So now let me introduce Professor Christian Debry, who is an ENT surgeon at the University Hospital of Strasbourg, France, where he specializes in rhinology and skull base surgery. Professor Debry is co-director of the Experimental Laboratory for Skull Base Surgery and a member of the board of the French ENT Society and French College of ENT and Head and Neck Surgery. Professor Debry is the lead researcher in investigating the safety and effectiveness of cavity. It's with honor and great pleasure that I turn the webinar to Professor Debry and eagerly look forward to hearing about his experience with cavity. Professor Debry, we'll let you share your screen and the floor is yours.
Thank you very much, Professor Levine and Professor Gerek. I am very happy to have the opportunity to present you the experience of the University Hospital of Strasbourg regarding the use of the new minimally invasive approach for bleeding management and support of intranasal structures. As you know, intranasal bleeding is one of the most frequent ENT emergency. Epistaxis impacts 60% of the population at least once during their lifetime. In our emergency department, it represents more than 12% of admissions and 25% of hospitalization. The cavity consists of an asymmetric balloon and a deployment guide, which are more precisely described in the following video. What you can see from left to right is atraumatic distal tip, a low pressure asymmetric balloon, adapt to anatomical variation, and on the right, the proximal tip for fine tuning of balloon positioning. Middle, there is two markers for optimal depth positioning, and below, Luer lock, it's a valve for inflation or deflation with air, not with water, but with air. You can see now a small video.
Cavity offers an alternative to nasal tampons in the management of spontaneous bleeding or during nasal and sinus surgical procedures requiring packing. Cavity is inserted parallel to the hard palate along the floor of the nose. The balloon is slowly moved forward in the nasal cavity until the first marker reaches the nostril. Depending on the bleeding site, the balloon may be advanced more posteriorly without going further than the second marker. Once cavity is positioned, the balloon is inflated with air using a Luer lock syringe. The syringe is filled with 20 to 25 milliliters of air and connected to the valve. The piston is pushed gradually until reaching 10 milliliters while checking the patient's possible pain. This 10 milliliters pre-inflation ensures a progressive unfolding of the device. After the pre-inflation phase, the deployment guide is removed. The green atraumatic tip located at the proximal end of the deployment guide can be introduced into the breathing channel to fine-tune positioning. Cavity is inflated with the remaining air until bleeding is stopped, without exceeding 25 milliliters. The cavity balloon can be deflated because of the bidirectional valve, and it can be repositioned with the deployment guide at any time. The cavity is easily removed. A syringe is connected to the Luer lock and the balloon gradually deflated. The cavity is gently withdrawn by pulling on the valve tubing or on the breathing tube with a surgical instrument.
Studies on specimens show very clearly after injection of a contrast agent like lipiodol, an uniform compression of the nasal cavity and a progressive conformation to the anatomical structures, including the sphenopalatine artery. Therefore, the cavity device is versatile and the physician can precisely manage balloon inflation in order to stop bleeding while maintaining optimal patient comfort. The balloon allows an adequate compression of the SPA as shown with the arrows, but is not suitable for bleeding originating from the nasopharynx. What are the results of pilot study? Let me now share with you some results of this pilot trial performed at our institution. This study was primarily designed to provide data regarding the safety and performance of cavity in the management of epistaxis in an emergency setting. The secondary objectives were to assess general complications like pain, infection, synesthesia, granulomas necrosis, septal perforation, and evaluate patient quality of life, especially pain, account device introduction, inflation, and removal. The most representative pathologies were, as usual, cardiological history with anticoagulant and antiplatelet therapy for 8 out of 10 patients. The epistaxis were unilateral in all cases. Bleeding site was equally distributed, anterior, posterior, or antero-posterior. Cavity was used after failure of bidigital compression, each case in patients requiring tamponade. Complete control of epistaxis in 8 out of 10 patients, efficacy in bleeding. Recurrence at 24 hours for 1 patient, recurring adjustment of inflation to control bleeding, and severe recurrence at 48 hours for 1 patient, recurring surgery by sphenopalatine artery, ligation under general anesthesia. One of the major points of interest of this balloon is the mild pain during its deployment, thanks to the deployment guide allowing an optimal, atraumatic maneuvering and positioning of this device. Upon inflation, pain was on average at 6 on a visual analogic scale. At V4, fourth visit at 1 day, pain has decreased to reach 2.5. Noteworthy cavity removal is almost painless, only 1.6 on VES, and no serious adverse events related to the device were identified. Now, let's discuss potential other indications in the cavity. There is a small video. The cavity balloon can be used as a support following a scale-based defect repair. We can see here something very simple. It's a small meningocell. We need to be cauterized and will be retracted. And what is important, what you put in place the cavity is to be under endoscopic control. And after, the pressure is adapted when inflating. Such a use has become almost systematic now in our practice. But there is two other indications. So you can see here, okay, the cavity is in place. But there is other indication for us. The use of the cavity after ethmoidectomy has become a frequent indication. It allows to shape the ethmoidal cavities to allow a faster healing of the damaged mucosa and structures, and consequently avoid blood accumulation in the nasal cavity. Cleaning and rinsing the cavities by nasal shower becomes therefore easier and allows a better nasal ventilation, improving the patient quality of life. Small here. More than 50 procedures have benefited from this technique in our ENT department, and a comparative study between two groups with and without balloon is planned in 2021. What is important, forceps must be used backwards and forwards in order to ensure the stability of the device at the end of the procedure. In those indications, the balloon stays in place between 1 and 4 days, but future clinical studies should better specify the best duration of implantation. There is certainly other indication like septoplasty or rhinoseptoplasty, perhaps we discuss after at the end. And why not maxillofacial surgery after osteotomy? An important septal deviation, not easy to appreciate in an emergency case, may cause difficulties in the balloon placement. The same problems are encountered when using nasal tampons or double balloon catheters. However, the atraumatic green distal portion of the deployment guide and of the balloon itself allows to navigate through such anatomy. When positioned, cavity may move secondary. It's essential in this case to ensure to good positioning of its proximal part, I repeat, as well as correctly appreciate its level of inflation. If these precautions are respected, in all cases, the patient can be discharged with the balloon in place for 2 to 4 days without facing subsequent balloon displacement. It should also be noted that those very rare displacements may occur within an hour or a few hours max after insertion, those requiring rapid monitoring before leaving hospital. In conclusion, in our experience, cavity is safe and efficacious, easy to use, causing mild to moderate pain during treatment, and almost painless. Icon removal could be used in ambulatory treatment and have potential to be used in multiple specialties, ENT, yes, but emergency physician, neurosurgeons, maxillofacial, plastic. Lastly, in an era in which particularly aggressive infection like COVID-19 can emerge, the design of the product may present an interest by limiting the risk of prolonged hand-to-nose physical contact between healthcare professionals and patients, as well as relieve hospital physicians' workload. So those first results will have to be confirmed in larger randomized control. Thank you for your attention.
Thank you, Professor Debry, for your excellent perspective, for your excellent talk and the prospective work you've done on cavity. I think this really tells us quite a bit about the safety, the ease of use, the comfort, and really in something that is new and different in what is a very difficult problem. Now, we have planned this webinar purposely to have time for us to have questions and to have engagement and interaction with the panelists. So I know that there are some of you where French may be your language of choice. If in fact you wish to give a question in French, it will go to Professor Debry. It will be translated, his response will be translated in English, and the question will be translated into English. So those of us for whom French is not our first language will all be able to take part in this conversation. So we've purposely planned that. Really, for Professors Debry and Gerek, I really want to thank you for the research, the work that you've done, the overview, and that will really be able to pull this together for our conversation. So let's open this up to the questions that we may have. Maybe even before we begin and I get to those questions, let me just say one word about my experience in the United States where I operate. First, this is a product that is now registered in the United States, recently introduced. I've had some clinical experience myself in managing epistaxis in one patient. I think I, like most of us, do not like to manage epistaxis. It disrupts our day. It disrupts everything we're going to do. And this has become a way that has been quite efficient for those patients with acute epistaxis, and is offered me and my staff, our emergency room physicians who are not ear, nose, and throat physicians, a way that they can manage this. I've had my own clinical experience in exactly what Professor Debry has mentioned to us, and that is in revision sinus surgery, where there's already a large ethmoid sinus cavity. I'm going in to remove polyps, scar tissue, and where there is some bleeding just because of the scar and revision surgery. And I've had a couple of patients now where I've inserted the cavity balloon. Our patients come from a great distance. They can go home with this. They can return to me in a couple of days and easily have the balloon removed. It is, their comfort level is exactly as described in the prospective study that was performed at Strasbourg. I've had one instance where a local family physician, I instructed him, he's very skilled, he deflated the balloon, slid it out, and all was well. So that's been my perspective on this too. A question has come up from one of our attendees about is there a need to sterilize this, and what about sterility? What about instruments that you may use? Is this a sterile procedure? Is this a clean procedure? Professor Debry, why don't you tell us what your experience has been about sterility for the device, the place, the location of where you do this in a clinic, an operating room, and the sterile situation. Please comment on that.
Okay, Philippe.
Oui, Christian, la question est à propos de la stérilisation du produit. Le produit est livré stérile. Donc tu peux juste...
Yes, okay, thank you. Yes, I read it. Thank you very much. Okay, there is, it's not necessarily the cavity arrive is sterilized before. It's necessary to sterilize it, just use one time, just one time. It's not necessary to sterilize it before to use it.
There is a question for Professor Debry regarding the use of the device as a replacement, a potential replacement for Doyle splints or packing post-septoplasty, and what type of clinical benefits can we expect? Translation in French. Est-ce que ce dispositif pourrait remplacer les attelles de Doyle et le packing post-septoplastie, et si oui, quels bénéfices en attendez-vous?
Alors oui, car le fait de gonfler très doucement et à la demande permet d'avoir une parfaite équilibration de chaque côté de la cloison septale. Et d'autre part, ça évite de mettre un packing parce que c'est très doux à retirer.
Translation in English of the response. The inflation is pretty gentle and will not damage structures. Therefore, it could potentially be used as a replacement, in particular, of traditional packing.
Let me add a comment on that. One of the challenges that I have had over my years in rhinology has been in managing nasal septal perforations. This is very frustrating for all of us, and I'd like to hear Professor Gerek's comment in a moment. But the times that I have tried to use mucosal flaps that I've rotated in the area or a cartilage graft, I've always worried in the first couple of days of displacement of the flap or displacement of a cartilage graft that I would put into the nose. I've been concerned about putting packing because of the severe pressure, and therefore, while I have not done this yet, I think this would be a place and an indication where I would see this in what is a common problem, septal perforation, and a challenge and difficulty that we all have. Professor Gerek, your thoughts and comments, and if you disagree, this is an open discussion and we are colleagues. Please tell me how you see this.
Yeah, I absolutely agree with you on this issue because we do not want any kind of pressure on the septum after any kind of septal surgery or repair of a septal perforation by cartilage or by having a flap there. So pressure is the problem, and pressure is also causing the nourishment of the structures there. So if we want to put something there to stabilize our flaps or cartilage or the septum, it must be soft and do not prevent any kind of circulation there. I agree with you.
Yeah, no, please go ahead, finish. I didn't mean to interrupt you. You had another thought.
That's what I'm saying. Okay.
So let me ask you this, and then we'll ask Professor Debry in a minute. If you were going to use it in this way, ideally, how long would you want to leave a balloon in place for support?
It should not have much pressure or do not have much inflation, but it should not be more than 2 days.
Very good.
Professor, not for epistaxis, just for to stabilize the grafts or flaps when we have to do any kind of septal perforation surgery. Just for septoplasty, it's the question whether we should need to use any kind of disciplines or any kind of packing.
Professor Debry, how long have you left the balloon in place? Is it only for 48 hours? Are there patients where you have left this for a longer period of time?
Yes, a period of time. I am reading the question. Is there a recommended time to remove the cavity? For epistaxis, it's for 2 days. 2 days, no more. If after 2 days we have one case before it continues to bleeding, so we operate them. It's our procedure. It's 2 days. For other indication like post-ethmoidectomy, we like to keep in place the cavity between 1 and 2 days to conform the cavities and to have better cavities after, because we, in our experience, we have less crust, for example, and there's a better quality of life for the patients. The maximum for us to keep in place the cavity was 4 days, 4 days, and it was for a very special for lateral turbinoplasty associated with ethmoidectomy to keep in place the inferior turbinate. There is another question that you got experience is skull-based surgery, especially when you use nasoseptal. Yes, we have. It's one of major indication. It's very useful after nasoseptal flap. The nasoseptal flap is not always alone. it with graft like cartilage or some bone. And at the end, there is many slices. And at the end, we have when there is a large defect, the nasopharyngeal flap. And when you use it, the cavity, you can see under endoscopic approach, endoscopic view, the inflation, very soft inflation, and you stop when you see all the reconstruction is okay, and the upper part of the balloon comes in contact of the reconstruction of the skull base defects. So it's very useful. And now at each time we use it. We are not alone because we have some neurosurgeon. We are working with us too, and we use together because we operate together. I think they are very fun of that because it's not possible with classical balloon. Another question is, did you using water instead of air to inflate it? No, air it's much better because it's more soft than the water. Water is too hard, and air is more soft at the contact of the tissue. You have to use air, not water. We tried before water, but it's too heavy, and the contact with the mucosa is not so good. So you have to use it with air. Another question and concerns the pressure of the flap. The pressure of the flap is not, it's the same question, it's that before. So you have to look with the endoscopic approach, and you look immediately when it comes with the contact of the repair of the defect. So you stop because everything it is placed and nothing can move after. And we keep it placed in this case about 3 or 4 days because before we move in.
And when you've left these balloons in for 4 days, you showed us those beautiful images from the data, the prospective data on pain. You know, pain is one of the big issues when we put in these posterior packs or many of these other techniques that Professor Gerek showed to us. And that's one of the concerns for patients. When you've left this balloon in for 4 days after, let's say, skull base surgery, what have you found is the degree of pain relative to other things you have done for skull base surgery? Is this the same? Is it more? Is it less? Where is the advantage here? If you could talk about that, and especially the patient experience of having this in place for a longer period of time.
The question est, ouais, comme Philippe, quand on enlève, hein, c'est ça. When we remove, what question is when we remove or fed the balloon, what can we see? Yes.
No, well, first tell me just about during the time the balloon is in place.
Yes.
That's one part. What is during the time the balloon's in place? How much discomfort is the pain having when you leave it for a longer time for skull base surgery? And then secondly, the second part is, what does the tissue look like to you after epistaxis and leaving the balloon in place? What does the tissue look like after skull base surgery? And what does the tissue look like?
Okay, with the skull base surgery or ethmoidectomy, it's nearly it's nearly the same. I think everybody could have their own experience, and we see there is less crust because coagulation went around the cavity, and it's more easy after to have an endoscopic approach or all the cavity when just we remove it. If we have not, if you have with the system, we think there is less crust, less hematoma, and there is a better view and better quality of life because the nasal cavity are more free at each time. So it's not perfect, but it's much better than other technique we used before because it conforms all the cavity after it stay in place more easier.
I think one of the things
your first question, sorry,
go ahead,
first
please.
question.
Well, no, I was going to say, I think one thing we need to emphasize, and maybe we have not made this as clear as we should, that one of the big advantages of the cavity is the ability for the patient to breathe through it, to exchange air. And is that not correct? One of the big problems we have when the nose is packed is, of course, that feeling of obstruction in the eustachian tube. Am I correct in saying that there is ease of breathing for the patient through the device?
Philippe?
La question concerne le tube qui permet au patient de respirer. Est-ce que ça lui amène du confort par rapport à du packing traditionnel?
Très honnêtement, le confort, oui, à condition en fait de cleaner régulièrement avec de l'eau. Et dans ce cas-là, ça apporte un confort. La respiration n'est pas normale, mais elle est appréciable. Si jamais on ne nettoie pas régulièrement par le tube, dans ce cas-là, comme classiquement, il va se boucher parce que derrière, il va y avoir une coagulation un petit peu autour. Mais ça apporte un confort à condition d'avoir des soins quotidiens.
Translation in English, the breathing channel adds comfort to the patient on the condition that you ensure regular lavage of the breathing channel with saline or water.
Good. Professor Gerek, there's been a question for you, and that is, do you foresee the potential use in people outside of our specialty? Let's say a paramedic, someone in the Army, someone who is not an ENT physician, but yet who is confronted with epistaxis for whatever the reason.
Yeah, I agree. This product is easy to carry for the paramedics in their bag. They can carry a few products together. It's sterilized already. So when you open the pack, you can easily implement it. If there was an epistaxis or nasal trauma to stabilize the nasal bones together, you can use this instrument in the field or war field. Also, this product can be used also in any kind of emergency departments by the paramedics or by the emergency doctors, emergency physicians. Also, it can be used in ambulances by the paramedics when you go to any accident field or any kind of trauma to the nose. If it bleeds, you can use it very easily. It's very simple, easy to use, and easy to carry.
I think that is so important, because when there is trauma, whether it is on a battlefield, whether it's a motor vehicle accident, there's multiple things that occur. Often there's facial trauma, there's chest trauma. The emergency medical team has many things they need to do. And sometimes while the bleeding is there and the bleeding is obvious, they want to quickly stabilize the nasal bleeding and get to the more life-threatening, maybe chest injuries or airway injuries. And if they can do something very quickly and easily, get the bleeding under control, they can move on to the other portions of the trauma that are critical. So I think
I agree with you.
Yes, please go ahead. Your comment.
If there was a severe bleeding from the nose, especially if it goes to posterior, also it may cause an airway problem at the same time in an accident area or the war field. So the first thing that we should do is to prevent any kind of bleeding, if it's especially from the nose, to protect the airway. The patient may be unconscious at the same time, so he couldn't get the blood out. So the airway should not be filled with the blood coming from the nose. So this is very important.
Yes, and you clearly said in your comments about blood getting into the stomach. We know that even small amounts of blood will mix with the stomach juices and create a large volume of material that will cause vomiting and complicate all the things you've already mentioned.
Yeah, the ENT surgeons are usually faced with the vomiting of the blood if the patient's bleeding from the nose or any kind of upper airway surgery. So actually, if we have too much blood, or maybe not too much, if we have a blood in our stomach, it goes to vomiting. And if the patient is unconsciousness, it's also an airway emergency at the same time.
Mm-hmm.
Yes, there is another question. Can be introduced under local anesthesia? Yes, it's under local or without local anesthesia because it's very soft. You can go through the nasal cavity nearly without pain, and except when it's a very important septal deviation, but it's the same with a nasal packing or double balloons. It's the same. But it takes about 15 seconds or 20 seconds. It's very quick, less than 1 minute to put it in place. And it's, we think, for us in our emergency department, it's more quicker than before. There is a very, very important, important difference between that and between the nasal packing we did before.
Yeah. My experience has been the many types of nasal packing that Professor Gerek showed us are much more rigid. There is a large amount of material we're trying to get into the nose, and patients are much more uncomfortable as I am trying to insert any of those things that have been the other choices Professor Gerek said. And I know that when I am doing that, not only is my blood pressure going up because I am trying to control the bleeding, but my patient's blood pressure is going up, and it only makes for more bleeding. Professor Debry, your video beautifully showed that this balloon is small, it is narrow, it is easily and delicately inserted into the nose, and it is then when it is inflated that there is that pressure. And your comments about pain was during the inflation, not during the insertion. So I think this is a very big advantage to this technology. Professor Debry, is there you were going to make a comment, please?
Yeah, yes, yes, we think too, and yes, it's a very, yes, it's painless. It's true, it's painless. Each cases. I see another. I want to say something else about the pressure. The pressure is between average is about 12 and 15 cc. If it's not enough, sometimes 1 or 2 cc more and it stops. But sometimes if we go until 20 cc, there is absolutely no problem to stop bleeding, but sometimes it's a little more painful. So you have to decrease 1 or 2 cc, and it's okay because it's a balance in this case between the pain and the efficacious of the cavity. So it's very easy to equilibrate between pain and efficacy of the cavity. There is another question.
Okay, before you go to another question, please, a question as it relates to the amount of fluid you're putting in very quickly. There is the ability with the markings on the cavity to advance it another centimeter. If the patient is still having some bleeding, what do you do first? Do you advance the balloon, the cavity a little further, or do you put in more air? Which of those two would you do if initially the bleeding isn't controlled?
So we put more air. We put more air.
And then if that doesn't work, do you advance it another centimeter or you do not? You wait.
And in this case, we wait. And it's okay, we stop. If necessary, we are looking behind in the oropharynx as if some bleeding. So 1 or 2 more cc. But the average, I repeat perhaps your question, it's about 15 cc. It's okay, it's nearly all cases. If not enough, 5 cc more. If it's enough, you are looking 1 hour or 2 hours after, if it's okay before leaving the patient from the hospital.
Go ahead, another question. Go ahead.
There is another question. Are there any different size available? No, it's only one because it's not necessary between women and men because it's exactly the same. It depends of the inflation of the balloon. If the cavity are very big, you can inflate until 20 or 22 cc, no more. It's smaller. In this case, 12 or 14 is enough. And the result is immediate. In our case, you can see there is no blood and bleeding stop. So that's the explication. What we are looking for with this device is something painless, really, and quickly, because we spend a lot of time before to stop this bleeding. And I repeat, what is important to see is with the forceps to very quickly to see there is backwards and forwards, it's in place. There is no moving. And in each cases, it's very difficult when there is very important septal deviations. But it's the same with double ballonnet, as we said, or with nasal packing. It's always difficult when the deviations always. We try, we can go through in each case, but there is some pain in this case, sure.
There was a question that we had about cost. Now, we have physicians from many, many countries, and the health systems are very different. Reimbursement is different. But I don't, maybe both of you can comment about cost, especially Professor Gerek, because you have other technologies that you mentioned to us. But Professor Debry, you've had the greatest experience. How would you, can you say anything about cost that would help realizing that we have many health systems and that many people from many countries? Can you comment on cost in any way that would help us?
Yeah, this one costs not too much, actually. It's more easily affordable than the other surgical techniques to stop the bleeding. But probably in time, I believe, when it's widely used by the ENT surgeons, it will become more cheaper, I believe. Did you hear me?
Yes, thank you. Thank you. Professor Debry, are there other questions that have been sent directly to you that you have? Professor Debry, any?
Sorry, Philippe.
Il y a d'autres questions qui t'ont été posées en direct.
I can, yes, I try to, yes, thank you, but I can read them because I have any different size available, introduced under local anesthesia, but I can see other direct question. Philippe, tu peux me les traduire, je ne les vois pas. So I ask if you can translate because I can see other question on my screen.
No other questions for now.
Let me make well, let me ask each of you, if you we have only a couple of minutes left. Do either of you, let's begin maybe Professor Gerek with you, any final comments and thoughts that you would like to share as it relates to your presentation, as it relates to Professor Debry and the questions that we've heard? How we give a moment or two to summarize and give some final thoughts.
Actually, epistaxis is a very common medical issue, and sometimes, as I said before, it needs some surgical interventions or some application to stop the bleeding in order to save the life. So this type of products are make us more easier to handle with epistaxis problem. So thank you to Professor Debry that they designed this type of product, and probably in time we will have more chance to use it with
Debry.
Yeah, with maybe more cheaper in time.
Professor Debry, some final thoughts, and then I'll make some concluding comments. Your final thoughts.
So, so we have, yes, so to conclude, as we said, for what is necessary to have, we have many patients, and many for us, it about 50 patients. And so, as we said, we have a therapeutic for with more patients in the future, and more procedure. And we have groups with balloon for a different indication to try in the different ENT department in France, and perhaps in other country, and share our experience for the different indication like septoplasty or rhinoseptoplasty or other indication. But the most and the main indication was really at the beginning epistaxis. But after we find this new indication, and really are very pleased for us, like ethmoidectomy, and in each case, skull bale surgery for nasoseptal flap and other. So I think in in the future, near future, we have different and more indication and more patients to speak and to share our experience with different departments.
First of all, thank you. I would say, as far as for me and for my what I have observed, and this is a special, really special thanks to the work that you did, Professor Debry. What I was most impressed with, and you presented this to us, was how effective this was. The number of patients where this was successful, for especially the large number of patients who were on some anticoagulant. Besides patients who are receiving an anticoagulant, we often will see patients on chemotherapy, and with their chemotherapy, they have bleeding problems that are difficult. So these were difficult patients that you managed and you reported on in your study. The pain issue was very, very important, to see how little the pain was. So I was very impressed with that. And I see great use for me in my practice. Well, I would like to thank both Professors Debry and Gerek for their research and their clinical perspective on using the cavity in the management of epistaxis. And really a very special thank you to Dionysic, the sponsor of this webinar and the creator of Cavity, and their special thanks for their support in this technology that brings a method to assist our patients and physicians to manage this common problem. But lastly, I would like to thank every one of you around the world who's been attending this webinar. We hope this technology will prove valuable to you. Also, this webinar will be available for replay on social media and LinkedIn. Wherever you are in this world, we're all suffering from some very difficult and challenging problems with this pandemic. So to each of you, please be safe, please be well. My thank you to you. Thank you, and have a wonderful evening. Goodbye.
Goodbye. Thank you very much.
Thank you, sir. I have the same wishes to you and to all participants. Yeah.
Bye, Gerek.
Thank you. Hope to see you in another webinar together.